Good afternoon, dear professors and dear colleagues. Today I would like to present a brief summary of my research regarding transrectal ultrasound-guided prostate biopsy after PSMA PET-CT in diagnosing residual/recurrent prostate cancer. A quick overview on prostate cancer regarding incidence, histopathology, diagnosis, and management. Prostate cancer represents a significant global health concern, ranking as the most prevalent male malignancy and the second leading cause of cancer-related deaths in males after lung cancer. The incidence rate rises demonstrably with age to the extent that 60% of males above 65 are affected. Diagnosis of prostate cancer is based on clinical presentation is sometimes challenging, as it is often clinically indolent and may only present with obstructive symptoms similar to those of BPH. Moreover, patients commonly present late with manifestations related to metastatic disease occurrence such as bone pains or pelvic heaviness. Screening is done through digital rectal examination and measurement of serum PSA levels. And now for a quick overview of the imaging modalities used in prostate cancer. Of course, transrectal ultrasound is the most widely used initial imaging modality, and it's also the most essential imaging tool guiding prostate cancer biopsy procedures. Next, we have CT. However, unfortunately, despite advancements in MDCT technology, CT remains constrained in its capacity for detecting and locally staging prostate cancers. It only contributes to staging of metastatic disease, for which it is also considered limited. The sensitivity of CT in ruling out metastatic disease has been found to lie around only 38.5%. Meanwhile, novel techniques such as PSMA PET-CT have a much higher sensitivity, falling around 83%. Which will be discussed shortly. The integration of PET diagnostics using ligands that bind to the prostate-specific membrane antigen, also known as PSMA, represents a significant advancement during evaluation of prostate cancer. PSMA is a transmembrane glycoprotein. In PSMA PET-CT, a small inhibitor of this glycoprotein binds to the PSMA on the surface of prostate cancer cells. Radiolabeling this glycoprotein inhibitor with various radiotracers such as 68 gallium or more commonly 18-fluorocholine allows them to bind to cancer cells for various utilization. Following this binding, the PSMA tracer complex is internalized by the cells, leading to gradual accumulation of the tracer within viable tumor cells, allowing for their visualization on PET images. As for primary diagnosis of prostate cancer, PSMA PET-CT has demonstrated superiority to both multiparametric MRI and conventional PET-CT for primary staging. As we can see in this image here, this is a PSMA PET-CT fusion image showing intense tracer uptake involving the prostate, as well as a right internal iliac node and another left periaortic node. Also notable is the physiological tracer uptake, which is seen in the salivary glands, liver, and renal tubules. The second significant use of PSMA PET-CT lies within the confines of suspected biochemical recurrence, which is the main area of research that interests us here today. Biochemical recurrence of prostate cancer is defined by the AstroPhoenix consensus as either a serum PSA exceeding 0.2 nanograms per milliliter following radical prostatectomy, or an absolute rise of PSA of 2 nanograms per milliliter or more from the pretreatment nadir level after radiation therapy. PSMA PET-CT is now the gold standard imaging modality in patients with biochemical recurrence to identify residual or recurrent disease. While PSMA PET-CT boasts significantly improved accuracy as compared to conventional imaging techniques, yet it still has some inherent limitations. False negative results can occur. For example, a small lymph node metastasis that can fall below the spatial resolution of PET scanners, which is typically less than 5 millimeters, could be missed. Moreover, a minority of prostate cancers express low or absent PSMA, and so will unfortunately also read a false negative. The aim of this study was to assess the diagnostic value of TRUS-guided prostate biopsy as compared to PSMA PET-CT in detection of residual or recurrent prostate cancer in patients with biochemical recurrence. I have seen and assessed around 50 patients with pathologically proven prostate cancer throughout the period of this study. Of these patients, 16 have either continued disease-free survival, have been lost to follow-up, or unfortunately excluded due to metastatic disease occurrence. However, 34 patients have presented with either elevated PSA or a PSMA PET-CT scan positive for malignancy, and those have been further re-evaluated by prostate biopsy. patients have undergone a thorough clinical assessment, followed by a few lab investigations, a PSMA PET-CT scan, and lastly, a TRUS-guided prostate biopsy. Now we'll move on to some of our case presentations. The first case represents a classical concordance regarding PSMA PET-CT findings and biopsy results. Here we have an 85-year-old patient diagnosed with prostate cancer in 2022. He was treated by radiation therapy and has been on follow-up ever since. During his routine follow-up, he presented with mildly elevated PSA. His total PSA level was 8 nanograms per milliliters. He was then referred for a PSMA PET-CT. As we can see in this PSMA PET-CT fusion image, there's an intensely tracer-avid prostate nodule involving the left prostatic lobe near the apex of the gland. The patient was, of course, referred for a biopsy, after which histopathological data revealed positive for residual malignancy. The second case, however, represents discordance between PSMA PET-CT findings, PSA levels, and biopsy results. In this case, we have a 72-year-old patient who presented with obstructive urine symptoms during late 2022. His PSA at that time was around 8.5, and he was referred for PSMA PET-CT. PSMA PET-CT fusion image here shows only mild heterogeneous PSMA activity throughout the gland. There are, however, no definite tracer-avid nodules seen within the gland, and these findings were reportedly attributable to BPH. He then underwent a TRUS biopsy, which also surprisingly revealed positive for prostate adenocarcinoma. For the last case, also representing discordant findings, we have a 63-year-old patient with pathologically proven prostate cancer. He had an initial Gleason score of 9. His routine PSA measurements were all within normal range, with his last PSA level at 1, done at 2023. The patient was then referred for PSMA PET-CT later that year. PSMA PET-CT fusion image here shows mild heterogeneous background prostate activity. However, there are no definite nodules also seen on this scan. However, the decision was made to biopsy this patient given the high initial Gleason score in order to identify any residual disease. TRUS-guided prostate biopsy was done and was surprisingly also found positive for residual malignancy. Moving on to the results. For the study descriptives, the study was carried on 34 male patients. The mean age was 69. As per the radiological outcomes, PSMA PET-CT was reported positive in around 68% of patients and negative in the remainder 32%. However, biopsy results were positive in about 85% of patients and negative in the remaining 14%. 29 of the study participants had a positive biopsy result, although 19 of them had a PSMA scan reportedly positive for malignancy. However, the remainder of the 10 patients were reported negative for suspicious PSMA-avid prostate nodules. This implies poor association with the PSMA status. Median PSA was also found to be significantly associated with positive PSMA status, as the median PSA for patients reported positive for malignancy was 8 nanograms per deciliter versus only 1.3 for those reported negative for malignancy. This implies that most of the patients reported positive has a higher mean PSA value, which is statistically significant with a p-value of less than 0.008. Reviewing the diagnostic performance of PSMA status as a predictor of biopsy results, it was noted that out of the study group, 29 patients were positive for malignancy, as proven by pathological diagnosis. 19 of them were true positives as reported by the PSMA scan status, while 10 patients were considered false negatives giving their negative PSMA scan for residual malignancy. Only 5 patients had a negative biopsy result, with a single patient having a negative scan, which is considered the true negative, and the remainder 4 patients, however, had a positive PSMA result, which is considered in this case to be a false positive. It was noted that PSMA status is an acceptable predictor of positive biopsy results. A positive PSMA status has a positive predictive value of approximately 83%, which means that a case with a positive PSMA status has an 83% probability to have a positive biopsy result. Looking at the diagnostic performance of SUV max measurement as a predictor of the biopsy results, this ROC curve shows that patients with a PSMA scan having measurable SUV max of values of 7 or higher had a specificity of nearly 100% to predict positive biopsy results. Finally, to sum up, our study concluded that PSMA PET-CT has a high positive predictive value for detecting prostate cancer. PSMA PET-CT has a low specificity to diagnose residual disease, and that measurable SUV max has a high specificity for predicting positive biopsy results with an optimal cutoff value of 7. And finally, we recommend that PSMA PET-CT should be used for initial diagnosis and staging of prostate cancer, but not for diagnosing residual local disease after radiation therapy. Another biopsy is advised prior to stopping androgen deprivation therapy in high-risk patients, as PSMA PET-CT showed a high false negative rate for detecting residual disease. Thank you.
شكرا دكتور يوسف.